merci beaucoup David Sanders. Et maintenant, j'ai le plaisir d'introduire le topo de Nick Trott, qui est un diététicien spécialisé en gastro-entérologie et je dirais quasi spécialisé aussi dans le régime sans gluten, qui a une expérience étonnante et qui va nous parler de tous les aspects du régime sans gluten, vu dont sa profession est extrêmement importante pour le suivi et le bénéfice des patients. Donc, Nick Trott, it's to you.
Thank you so much. So good afternoon, everyone. My name is Nick Trott. It's wonderful to be here. I'm a gastroenterology dietitian from the Royal Hallamshire Hospital in Sheffield. Today, I'm going to be talking a little bit about the nutritional and dietetic aspects of the gluten-free diet. And I've named this talk after my favorite French author, One for All and All for One, partly because I want to be talking a little bit about whether the gluten-free diet should always be applied in the same way for all patients we see with gluten-related disorders. I also want to talk a little bit about common mistakes that patients can make when following a gluten-free diet, as well as addressing some of the evidence base about whether a gluten-free diet is inherently unhealthy. And then to start with, I really want to look at a little bit about the major challenges in transitioning to a gluten-free diet. So we do know, and I think I've got this out, there we go. We do know that the gluten-free diet is difficult to adhere to. Whatever metric you use, dietetic review or validated questionnaire, you can see from this slide that adherence to the gluten-free diet around the world is very variable. And I think as clinicians and dietitians in the area, we can sometimes have a tendency, should we blame the patients? You know, why won't they follow a gluten-free diet? Why is it so hard? And I personally think we should never do this because there are economic, cultural, treatment burdens and healthcare disparities that mean the diet can be difficult to follow. And I just want to touch on some of these. So this is a seminal study in the area now from our American colleagues, and it was looking at the perceived treatment burden of celiac disease versus other chronic conditions such as hypertension, esophageal reflux, diabetes, inflammatory bowel disease. And what you can see from this study clearly is that celiac disease is secondary only to end-stage renal disease, patients on dialysis. And that can be quite a shocking result. However, as the authors were pointing out, with celiac disease, the patients have to have a constant awareness of their food environment. They have to be constantly aware if they become cross-contaminated, they may become very symptomatic. And this does result in a large treatment burden with the condition. Now, last year, this seminal systematic review came out from a Canadian group, and I really encourage you to read this paper. They used a social ecological system to look at different levels of barriers and facilitators to the gluten-free diet. Now, that infographic is a little small, so I've enlarged it in this table here. And I think what I took away from this study, particularly as a therapist and a dietitian in the area, is there are really only two areas that we can largely influence in clinic, and that's the individual and the intrapersonal. So we can enhance self-belief and knowledge of the gluten-free approach. We can give patients techniques for navigating social situations. But as we move up through the organizational, community and system areas, I think it becomes harder for us to influence those areas directly. The awareness of the gluten-free diet socially, poor labeling maybe in some countries, access to gluten-free on prescription can be problematic. There's one area that is personal for me, and that is the level of dietetic support for patients. Certainly historically in the UK, we know that maybe up to 60% of patients have no dietetic input. They may be diagnosed and just directed to Celiac UK's website. And last year we did a national survey from our centre, and it suggested about 50% of departments in the UK have no pathway for celiac disease. So there are some mistakes that patients do make. And I think we use this model of patient education, establishing the diagnosis and moving on from there. And particularly for patients, I think there's two areas that they do make mistakes in. What is gluten and how to define a gluten-free diet. And these things are fundamental because it leads then to cross-contamination and a lack of understanding and awareness. Now, I'm going to invite you to participate. The next screen has got a question I'd like you to consider. So what is the daily gluten threshold for patients with celiac disease? Is it A, 1 gram, B, 500 milligrams, C, 10 milligrams, D, 20 micrograms, or E, none? And I would invite you to vote now. So the answer is 10 milligrams. Now, we like to make this more realistic. That's a little bit subjective for patients. We like to make it more objective. So if we think about 10 milligrams in the real world, I want you to use a perhaps culturally appropriate food. So if we think about how much gluten might be in one standard medium-sized baguette, it's probably around 4.5 milligrams or 4,500 milligrams of gluten. So if someone with celiac disease were to eat that over the day, they've just had about 450 times the upper daily suggested cutoff point. Now, we also like to spend a lot of time trying to delineate what gluten is for patients. Fundamentally, if they can understand this, they can work out logically a lot of where gluten is in labels and when they're out, and know how to communicate it to waitering staff. So we do spend a lot of time going into detail, and particularly even talking about some of the biochemical differences of gluten, and a lot of patients really appreciate this level of detail. The other thing we do is look a little bit of learning from our psychology colleagues, particularly around poor emotional regulation and maladaptive coping strategies. When you say to a patient you have to go gluten-free, represented by our friend Homer here, often the response you get back is this.
That's a problem for future Homer. Man, I don't envy that guy.
So we really want to direct patients to have a future-focused internal motivations for adherence. And we encourage that not because dietitians or clinicians say, but because patients understand it limits comorbidities and potential problems in the future. We also like to identify risky situations for people. I think we would all think about this as a risky situation for other reasons, but we do try to get patients to plan for when they're busy and stressed, so they're aware of what may be coming up. We also use enlist and mobilize social support. We have group clinics pre-pandemic, and we've moved this now online. And we also normalize and validate difficulties and emphasize that things will become easier with time. And then we don't have this in the UK yet, but our American colleagues now have specialist gastro-enterology. And I think in the future, this could be an amazing way of helping patients who maybe have depressive symptoms or high anxiety around some aspects of following the gluten-free diet. So I do want to move on a little bit about gluten-free diet and whether it's unhealthy. I think primarily we often think of clinical benefit when we think of the gluten-free approach to reduce villus atrophy and malignancy and increase bone density. But of course, patients present with a range of conditions, bile acid salt malabsorption, concomitant IBS and allergy we see, as well as, diseases, non-communicable diseases like obesity and dyslipidemia. And I think the gluten-free diet has got unhealthily labeled as being inherently healthy. If we look at some headlines from the UK, from those reliable publications like The Sun, they're sort of saying gluten-free diet can give you deadly diabetes and increase your risk of heart disease and expose you to arsenic and heavy metals. However, if we look at the papers behind these studies, what we actually find out is they are all cohort case series observational. And the authors point out they're unable to establish causality, and there's confounders in these studies. And also the issues in all these papers the authors highlight, their dietary choices, reduced whole grains, substitute grains, and over-reliance maybe on specific grains. And as a dietitian, when I see this, what I think is these things are modifiable. They're not inherent risks in the gluten-free diet. Patients need advice and support to be guided nutritionally. And I would argue one of the benefits of having a dietitian involved. Now, gluten-free food products, I think, in the past have had a negative view. And this review, I think, is really helpful in this regard. In the orange, you've got gluten-free, in blue, you've got standard products. And in most areas, what you can see, if it's saturated fat or total calorie content, carbohydrate or fiber content, the gluten-free diet is often outperforming standard products in terms of having less saturated fat, more dietary fiber, and less sugars. So again, that's not universal for all labeled gluten-free foods, but it's certainly becoming more common, as this study has highlighted. So I think, again, patients need to be given advice and support to make correct, informed choices with their food products. So I do want to move on to this idea, is the gluten-free diet the same for all patients? Particularly in our centre, we have a lot of non-responsive celiac disease referred in. We're one of the national centres for refractory celiac disease in the UK. Obviously, non-responsive disease patients will appear to follow the gluten-free diet, but have ongoing symptoms or mucosal injury or positive serology. And these patients may be treated by nutrition. And again, I'd invite you to participate by answering a question. What dietary approaches can we use in non-responsive celiac patients? A, the autoimmune protocol diet. B, the super-sensitive gluten-free diet. C, gluten contamination elimination. D, the low FODMAP diet. Or E, ketogenic. So the answers are C, gluten contamination elimination, and D, low FODMAP. And I'd like to go on to a little bit explaining about that as well. So in our centre, we use a biopsy-led approach. When patients are referred in with non-responsive disease, we look at what the biopsies are telling us. These patients often have a lot of buy-in to have a repeat biopsy so they can understand what's going on themselves. In patients who are ongoing symptomatic, particularly with an abnormal duodenal biopsy, obviously we will review their diet to see if they're following a gluten-free diet properly. And in that case, if they are, we may consider a hypersensitive approach that I will talk about in a moment. If they have symptoms but a normal duodenal biopsy, we may consider them to have functional symptoms, possibly IBS, and we will use a different dietary approach in that instance. So one of the super sensitive approaches was this seminal study from our colleagues in Cambridge. And what they did, they had several patients have rebiopsy, and they cut out gluten containing wheat starch, barley malt, and porridge oats that were gluten-free from the diet. They had about 90 patients in their cohort with persistent villus atrophy. 29 patients were given this approach, and about 18 patients, about 20% had mucosal improvement. However, I think this study the validity of it is somewhat undermined now. The majority of cases in this study were eating foods that were up to 200 parts per million, and the legislation has since moved on. Now gluten-free label foods are 20 parts per million, and I think some of the patients in this cohort may have improved on what we would call class as current standards. So I think this approach may have less validity today. The other hypersensitive approach is what's known as the gluten contamination elimination approach that was proposed by Professor Alicia Fasano's group in America. And this approach is highly restrictive. If you think of this food model here, it cuts out a vast array of foods. No grains except for rice, no processed foods, no label gluten-free foods, no dairy for the first month. It's only fresh fruits, vegetables, meat, fish, and poultry. It's very restrictive. And when we look at the results from the study, there was about 1,300 patients over a 6 to 7 year period. Only 2.3% of the cohort were offered it, and ultimately only 14 patients had mucosal recovery. So the approach does work, but I think we have to be very careful with patient selection. I've met patients who tried to undertake this themselves, and it has resulted in eating disorders and disordered eating. So we have to be very careful. Certainly in our centre, most patients do not opt for this approach. They opt for a medical management route. If you are interested in this or instigating it with your patients, I'd really encourage you to maybe to read this paper from Alicia Fasano and colleagues highlighting the indications for use and particularly important of dietetic review for possible gluten exposure. Now, from celiac disease and IBS, which I think is we're all becoming aware can co-occur in patients. The low FODMAP approach is something that we do use. I very much refer to this as an approach, not a diet. It is not a diet for life. It's a three-phased approach. Restriction for just 2 to 6 weeks. We find in our centre 2 to 3 weeks is long enough to know if it's going to work. Then it's a re-challenge of the subgroups to tolerance. So we re-challenge fructans, galactose, fructose, polyose, and lactose. And then there's a long-term personalisation phase. All the studies on the low FODMAP diet were done with dietetic-led intervention and involvement. The low FODMAP diet should always be delivered in consult with an experienced dietitian. It is not a risk-free approach, but it can be life-changing for some patients. Again, in our centre, we will only use it in celiac patients who have demonstrated a negative remission biopsy. So we can separate out autoimmune symptoms from functional symptoms. I also just want to touch on the difference between the gluten-free diet in non-celiac gluten sensitivity and IBS. So in our centre, when we presented with non-celiac gluten sensitivity or gluten-sensitive IBS, it is a less restrictive approach. We are not suggesting to patients with non-celiac gluten sensitivity that they follow a celiac gluten-free diet. They don't have to worry about cross-contamination or any of the comorbidities as far as we know with celiac disease. So the threshold really is in grams for most people. Well, obviously, as we've already mentioned, the threshold in celiac disease should be in milligrams. And interestingly, we actually have some data to back this up now. In this fascinating study published last year from a Canadian cohort, this was patients with diarrhea predominant IBS. They took these patients on a gluten-free diet and they measured to see if they had anti-gliadin antibodies present in the blood. And sure enough, the patients with IBS anti-gliadins present did better on the gluten-free diet. These are patients who had celiac disease excluded on biopsy. And even though they weren't following the diet strictly, their symptoms still resolved. So we now have evidence that the gluten-free diet in gluten-sensitive IBS does not need to be as strict as it maybe should be for someone with celiac disease. So I would like to wrap up the talk by just highlighting some take-home messages. As we can see from this little slide on the side here, that adherence to the gluten-free diet is difficult and can be variable. But I think there's reasons for that, like a dietetic and medical support, economic factors, product availability. And I think the current provision of dietetics in celiac disease is underfunded. And we need support, new support modalities to account for the fact there's a heterogeneity of people in this cohort, both in celiac disease and non-celiac gluten sensitivity or gluten-sensitive IBS. And there's also, particularly in celiac disease, an increased incidence of complex disease. So I really think we need to support patients appropriately, and particularly from a dietetic point of view. So I'd like to thank you all for listening and look forward to any questions.